Welcome to the Quillette podcast. My guest this week is Karleen Gribble. Karleen Gribble is an adjunct professor in the School of Nursing and Midwifery at Western Sydney University. Her research focuses on breastfeeding, particularly in situations of adversity, and she is a strong champion of the importance of mothers to their newborn infants. I'll be talking to Karleen about her article, The Desexing of Language in Women's Health Research and Care, a story of marginalisation of science, cultural imperialism, and abuse of power. This essay is a contribution to the volume, The War on Science. 39 renowned scientists and scholars speak out about current threats to free speech, open inquiry, and the scientific process. Edited by Lawrence Krauss. I hope you enjoy my interview with Karleen Gribble. You give a list of alternative words that people have used in relation to female reproduction in health literature and communication instead of the word woman. This is taken from an author called Millie Hill and her blog, which is called The Word is Woman. Really great title of the blog. And here are some of the replacement terms. People, individuals, humans, patients, someone. It's very, very specific. Uterus havers, people with uteri, very posh. Cervix havers, people with vaginas. Bodies with vaginas. Birthing bodies. Female assigned bodies. Menstruating personnel. I think that's my favorite. It sounds like you're at the head of some corporation and you have some policies around your employees who are on their period. Menstruating personnel reporting for duty. Menstruators, bleeders, menstruating individuals, bodies that bleed. Surely that's all bodies. Menstruating bodies, people who experience periods, people who period, people who menstruate, vulva owners, vulva people. I quite like that one, the vulva people. Someone with a vulva, birth people, non-males, non-men, non-prostate owners, individuals who have receptive vaginal sex. That seems very presumptuous. Womb carriers, those assigned female at birth. Reproductive aged persons identified as female, person with reproductive potential, person of childbearing potential, people with reproductive organs, people with female identified reproductive organs. I love the idea that your organs could have a gender identity. Individuals who have reproductive capacity. So, I mean, a lot of this language is it seems quite ludicrous and comic. When did this language first start to come into use, and what was the initial impetus behind this? Can you trace that for us, first of all?
Yeah, so these terms really started to come to the fore with health professionals and researchers working in areas to do with women's reproductive health in around 2015, 2016. And they were presented at the time as, this is something that we should use on an individual level when we're caring for or working with a population of female people who have a transgender identification and they identify, usually they were talking then about, this is a trans man. And so you would want to use language in one-to-one that would make this person feel more comfortable. And you would want to avoid terms like women and mothers and instead use the language that that person preferred. And to be honest, nobody really had any difficulty with that because that's really a very normal thing to do in healthcare provision, is using the language that people prefer for themselves. There are some exceptions to that, but it generally wasn't something that people were very concerned about. It really wasn't until 2020, in the middle of the pandemic, that things went a bit crazy and we had a lot of organisations that were starting to use this language in not just one-to-one or saying to use it in one-to-one, but using it for health communication more broadly. And that's where there is a big problem because, for a whole variety of reasons, which I'm sure we'll get into.
So how was this connected to the pandemic? do you think? Why was it just that people had more time on their hands because they weren't able to see as many patients one-on-one, and therefore they began going down some rabbit holes, the feeling of, I must be doing something, so maybe I can tinker with language? Or was there any particular event, publication, or other kind of moment which began this process? So you have figures in your article, and what you show is an exponential rise in the amount of desexed language used in health communication over that period. It's kind of extraordinary. There's almost like a patient zero happening around 2020, and then it just takes off. Is that just the usual snowballing effect of trends, or what do you see as the kind of driving force behind that?
Well, I think in terms of language, it is the sort of thing that you might see when a new term comes into use. So you might look at uses of words like selfie, for example, like it was a new phenomenon, something new, didn't exist before. All of a sudden we've got new technology and we've produced a new term and it's become very culturally relevant. And so lots of people are using it. The difference with this is that it's not new. The existence of women and girls is not a new thing, but it was a very new use of language. And it started to be noticed, and you can use this. You can see this by looking at how terms have been used in Google. You can look at the trends in use of language. You can see how frequently they're being used, and you can also see where they're being used. And if you look at terms, for example, like birthing people or chest feeding, those sorts of terms, you can see how it starts in the USA is the first thing. So all of this desexed language starts in the US, and you can see how the use has increased dramatically, like you say, but also spread around the world. And so it's a very clear pattern as to why during the pandemic. I mean, I think the pandemic it was like pouring fuel on the fire of lots of different things. And this was one of them. It was also a time when there was a need for a lot of communications, particularly around maternal and child health. And for the area that I work in around breastfeeding, the pandemic was a really big deal because normally with an infectious disease, you separate people who are infected from those who aren't infected. But what do you do if the infected person is a new mother and the uninfected person is her brand new baby? And so there was lots of concern around that. And so there was lots of health communications around what you do. And, not only were we having some organisations, most notably the US Centers for Disease Control and Prevention, saying we should separate mothers from their babies, but also the language was changing. And instead of talking about mothers, communications were talking about parents. And it's like there's a big difference for a newborn between their mother and their father. They're not equally important. You need to distinguish between the two.
Yeah, you said that during COVID, at one point it was believed that COVID would be extremely dangerous to newborns, and therefore newborn babies should be kept separate from their mothers if their mothers had tested positive for COVID, which was...
Well, I don't think that was never actually the case. It was evident from the end of February of 2020 that this infection really didn't cause a problem for children, that it really was an infection that was most risky for older people. But we have, like I said, the US CDC, they put out recommendations in the middle of February of 2020 saying if a new mother has COVID, that separation from her new baby is appropriate. And that recommendation did spread around the world, including to countries that have quite high infant mortality rates. So there's probably many, many babies that died as a result of that recommendation to separate mothers and babies. So, yeah, a confluence of both poor recommendation development. There was never any excuse for that recommendation to be made, but also just confusing language.
I want to just steel man for a moment or not steel man actually, I want to critique the reasons that are frequently given for the desexed language. And we can get into some of the complications that using desexed language causes. And one of the things that is often said is if you don't talk about people who have cervixes, young women who have transitioned to who are now trans men and identify as trans male will not know that they have cervixes or internal female sexual organs and will not understand that they need the same kind of health care as other women in that regard. And that seems to me like a very weak argument, actually, partly because I feel that if you are too young or have too poor an understanding of your physical body to know whether or not your transition has involved, for example, a hysterectomy. So you don't know when you transitioned whether or not you still have a uterus, cervix, etc. Then there's been a failure in a duty of care towards you, and you shouldn't have been permitted to transition. There should be informed consent, and you should therefore have a very, very clear and good understanding of what precisely has happened to your body or not happened in the course of the transition. So I'm kind of skeptical about the idea that trans men don't realize that they have cervixes, and that's why you need this kind of language or you would miss them. Am I wrong to be skeptical about that?
Well, I think it's not a good reason to change broad health communications. So I would say that generally speaking, a lot of women and girls have got very poor knowledge about their bodies. And I would suspect that young women who identify as transgender, so as non-binary or as a trans man, are likely to actually have poorer knowledge about their body than others. And that would partly be related to the issue that you raise. And I think that very often health providers are not being frank and honest with them and not communicating very clearly with them. And so they're not really understanding what the treatments that they have done mean. I mean, there's some really concerning information out there that suggests that this is the case. So including, for example, like a New Zealand government, I think it's a government website, and a Canadian one as well, that has a frequently asked question about phalloplasty. And the question is, will I be able to father a child after this surgery? And it's just is that a real, have people actually really asked that? And if they have, what does that say about their lack of understanding of the limits of medical treatment and what medical gender transition treatments are able to provide? So I think there is a low level of knowledge, but there's a low level of knowledge, like a lot of women don't know that they have a cervix. They don't know what that word means. It's a technical term for a part of the body that you can't see, and that a lot of women just don't even know. So that's why, one of the reasons why having health promotion, say for cervical cancer screening, that says, if you have a cervix, you should have a cervical cancer screen, is not effective communication, because a lot of women who are the targets for the communication will not understand that this applies to them. The other issue, though, is that we know what to do in terms of health communication for groups that have particular needs. And that is, we provide them with targeted information and communications. And so for this group, there's no reason to change the language that's used in the broader communications. That should be left the same. Plain language, communicate as clearly as possible. Just keeping in mind that a lot of the population have got low reading skills, low language skills, they've got low health literacy. So use as fewer words as possible and as plain as language as possible. And then you provide targeted communications for groups like this group, which would involve completely different language. And if you do that, then you meet the needs of the broader population, and you also meet the needs of the population who identifies as trans.
So what are some of the knock-on effects of that use of the desexed language. So we talked now a little bit about how that can lead to confusion, especially among the groups who are most in need of receiving this kind of health communication, like women who are less well informed about their bodies, who are maybe less well educated in general, perhaps lower in intellect, perhaps non-English native speakers, perhaps women abroad in poorer countries also, it's important to have a language that is just clear for everybody.
Yes, and it's important not just for it to be clear, but also for it to be acceptable. And one of the scandals about this is that these language changes have been made without there being research to actually identify what the impacts are likely to be. I mean, we can speculate, we can provide lots of examples of problems, and there's been very many where information has been miscommunicated because somebody has just gone in and replaced women with people. One of the classic cases is a UK NHS website, which talked about 80% of people will get pregnant within a year of having unprotected sex. And you're like, 80% of people? So somebody's just gone in and just replaced women with people as if it doesn't matter. And it does matter. And so you get those sorts of things happening really regularly in this space. But also, what we know that a lot of women, just from anecdotally and just from their response when language has changed, don't like these changes. They don't like being called birthers. They don't like being called pregnant people. They don't like being referred to as cervix owners. And so if this language is changed, how many, first of all, don't understand it, but also how many reject the language altogether? There's been just 2 studies that have been done on this. One was done in the US, and it was just looking at language around breastfeeding. And it confirmed that, if you replace mother with parent, that quite a lot of people will presume that that also includes fathers when that's not being meant. But also terms like chest feeding and body feeding as replacements for breastfeeding are just, women don't like it at all. And the women in this study, and it was a small study, only had 16 women in it. They were like, if I had those words on a survey, I would just screw it up and throw it away. I wouldn't have anything to do with it. So there's that sort of rejection. Larger studies been done in Uganda only last year, and they found that this language, they talked about it being offensive. They talked about it was being misunderstood. So they understood birthing parents to refer to both mothers and fathers. But, you talked about menstruators before. For them, when they heard the word menstruators, they thought that implied that you were doing it all the time, that women were, it was implying that menstruation was just happening constantly. So it just, and they talked about it being obscene. They just thought that this language was not good. So, so language has to be able to communicate what you intend to communicate. It has to be acceptable to the target audience that you're wanting to communicate with. And it has to, you don't want to confuse people. And these language changes confuse everybody. They absolutely confuse everybody.
Mm. Yeah. I mean, I haven't menstruated in quite a while, but I haven't ceased to be a woman.
That's right.
I could also have unprotected sex for as many years as I like without any risk, let alone 80% risk of pregnancy. It's, and it does imply when you talk about menstruators or menstruating personnel, I just love that. It implies that you are asking women to come in for the tests whilst they're on their period, or at least that's how I would interpret it, for example, rather than you're just trying to address women.
It has
So
become a bit of a coded
odd.
language.
Yes.
So it is meant, if you understand, so very often mothers is replaced with families in language, and people who are in the know can read something that talks about families and understand that they're really just talking about mothers. But if you don't know that, it just doesn't make sense, or it communicates something completely different from what you want to communicate. And I don't actually think, so this is being put forward as being about looking after the transgender population, but I really, like, if that is the case, a really bad job is being done of that. I'll give you an example. It's not in my book chapter or in any of my papers. It's actually in a paper that I'm working on at the moment. Some radiographers in the UK they did freedom of information requests to get copies of all of the standard operating procedures regarding pregnancy inquiries for radiographers. So if radiographers don't want to have an X-ray or a CAT scan of a woman who is pregnant if it can be avoided. And so it's part of standard procedure everywhere in the world to ask women within the age range of sort of 12 to 55, is there any possibility that you could be pregnant before they have an X-ray? But what's happened in the UK is that the regulatory body and the Radiography Society has brought out recommendations saying, well, you shouldn't talk about women anymore. You should talk about people of childbearing potential in order to ensure that people who are, females who are transgender are included. Because there's issues around individuals changing their sex marker and their health record. So they might be female and their health record says they're male. And if they've taken testosterone and had a mastectomy, then they might look like they're male when they're actually female. And so we need to make sure that they're included. But changing the language doesn't fix that problem at all. It doesn't deal with it in any way. You still have got a situation where people have incorrect health records. They can't be easily identified when they come in. And so it just seems to me to be absurd that this is presented as being more inclusive and being beneficial to this particular population and not addressing what the core issues are. And that is, how on earth do we get into a situation where people have got an incorrect sex marker in their health record? It's just insane.
Yeah, you gave a couple of examples here which I thought were particularly striking. The Lancet published a paper describing women as bodies with vaginas and quoted this phrase on the issue cover. Research published in the Lancet Western Pacific described the stigma of menstruation. So it was specifically about the stigma of menstruation and referred to study participants as menstruators.
Yes.
And the Harvard Journal of Law and Gender published a paper discussing deficiencies in maternity care for Black American women that described them as birthing bodies.
Yeah, it's very dehumanizing language.
Yeah, it's extreme. It's both counterintuitive and dehumanizing, but it also leads to, I feel that it signals, to me at least, it signals that my doctor or healthcare provider is guided by ideology rather than by science. And I think that there is some reason to fear that just using this kind of very convoluted language is actually leading people to do poor medical research. For one thing, as you point out, because of guidelines on referring to patients and subjects with this sex-neutral language, some studies are actually misleading about the relative dangers or prevalence of certain conditions or efficacy of certain treatments for men versus women, because they can no longer tell who in their study group was male and who was female on a biological level, because they have allowed participants to just identify as male or identify as female, and they can no longer accurately tell numbers of men versus numbers of women when they're looking at a study.
No, absolutely. And that's particularly an issue if you're looking at a condition or a situation where there's a large sex difference. And the obvious one with this is often discussed is in relation to violent crime and prisons. So we know, 90+% of people who are in prison in any country will be male. They will also be much, much, much more likely to have been convicted of very violent crime and sex offences. And a small number of individuals who are male being misrecorded as female can really skew the data on female crime. But this applies everywhere. And there are some things that are very sex specific. So, for example, pregnancy is very sex specific. But, there's a bit of Canadian research which was looking at the pregnancy involvement, was how they framed it, of young transgender people. And they didn't distinguish between the sexes. So even though there's a vast difference between getting someone pregnant and getting pregnant, it just wasn't possible to look at what that difference might look like in this population in this study, because they didn't collect sex data, and they certainly didn't disaggregate by sex. So that's, very much a problem. And I've spoken to academic colleagues who've been concerned, like they've got results from, say, they work in sports science and they've got a large data set, and they suspect that they have a number of people who've said that they're female and they're actually male, and it's, obvious in the numbers that they've got that there's an issue there, and they just don't know what to do about it. I think it's quite confusing and difficult for a lot of academics, because they're not trying to be political. They really often just want to get on with their research, and yet they're being put under all this sort of pressure, which comes through at all levels of research. So even getting ethics approval for a study can be quite difficult if you've got a committee that's saying you need to use inclusive language and talk about pregnant people rather than women. And, you can't do the research if you don't have their approval. And so they hold a lot of power. And that's a big problem. And then, again, you submit a paper to a journal. I've had many requests from reviewers asking me to alter the language. And then you also get requests at the level of publication. So once something's been accepted, even from editors asking for language to be changed. And one of the examples that I've got in my chapter is from the Lancet Global Health, where colleagues and I had written a letter to the editor about the need to ensure that breastfeeding women were taken account of in recommendations around vaccination for Mpox in the Democratic Republic of the Congo. So you think, this is it's a really serious issue. It's not an issue that everybody is concerned with, but it is an important issue. And yet an editor asked us to refer to chest-feeding parents. I mean, we said no, but of my co-authors weren't even really necessarily sure what that meant. I mean, one of them thought that chest-feeding parents referred to fathers, and they were like, this is not an issue for them. So, but also, why were they, there would be no chest-feeding parents in the Democratic Republic of the Congo. This is not a place where this concept has relevance at all. And so why were we being asked to change that language? It's really an imposition of a priority that's very, very Western. And that's where this is also offensive. And I think, you mentioned language before and health providers. One of the terms that I think that a lot of people also don't like very much is when they talk about sex assigned at birth or assigned sex. And again, I think that's really offensive in a global context where you've got many places in the world where being born female is life-threatening. Female infanticide is common in many parts of the world. And so the idea that you use a term that suggests that somebody has decided to assign a sex to you that then condemns you to, horrible sexism that, it can potentially be fatal is just, it's just so crazy, but also just so offensive. And there are many journals that require that language, that actually require researchers and academics to talk about assigned sex or sex assigned at birth.
Yeah, it also seems to me more fundamentally that it's very important. Medicine is one area in which it's important to be clear-sighted about the facts about the human body and about human biology and physiology. And it is one area that should be free from ideological and political trends and considerations about what it's sort of trending to say about people's bodies, as opposed to what are the actual just straightforward facts of the matter. And I was really struck that you made a grant application with some colleagues to the UK's National Institute for Healthcare Research, and your application, which was to examine what impact, if any, desexed language has on health outcomes for people. So you were going to simply study without necessarily having come to a conclusion already. And the research was rejected at the final stages of the grant applications by a set of people who, among other things, objected to the fact that you hadn't used queer theory in designing your study, which is absolutely extraordinary that in the field of medicine, you should be expected to be influenced by queer theory. I find that very concerning.
They also didn't like that we had used the word women and female interchangeably. So, I guess, as I mentioned before, it is a scandal that these changes have been made in language, particularly in health communications, without an understanding of who and how people are being impacted by it. And, and also how can any negative impacts be mitigated against? It's about finding solutions, really. And, just we couldn't get the research funded. And, we had support from 11 women's health organizations who were all saying, this is an issue for our organization. We don't know what to do. Whatever approach we take to language around women's healthcare, we get criticised, and we really need research to actually inform our response and our actions. And to date, that research still has not been done, and I would love to be able to get it up and running, because we need evidence. We absolutely need the research to be done. It's not good enough that when I talk to you about this, I talk about a study in the US that includes 16 and a study in Uganda. We need this kind of research to be done in places like the UK, places like Australia. Do it properly. Identify what the issues are, identify what works, what doesn't work, and find solutions. I'm very pragmatic and practical when it comes to this. I wouldn't be, it's not because of any particular ideology or approach that is underpinning this. It's like, how do we actually communicate clearly? And, what are the results of making this really fundamental change? I don't, pretend to think that there's not going to be negative impacts, because we've seen them. If you've got eyeballs and you've read some of these communications, there are some obvious problems, but we really don't understand it clearly, and we need research to work that out. And we also need research to actually persuade people to take an evidence approach to health communications around women's reproduction and around this issue, and to work out what works for those people who identify as transgender. I'm not entirely convinced that what people say works for them actually works for them in practice. I think that they don't get clear, plain language used to explain to them what their health needs are, what what the implications are, for example, of changing their sex marker in their health record. I think a lot of them think that if they've had cosmetic procedures or they've had hormone treatments, that they have literally changed their sex. And that's dangerous for their individual health if they change their sex marker in their health record. So I think, I'm very much in favour of let's work out what works for everybody.
Yeah. I mean, I'm concerned to see things like the US National Institute of Allergy and Infectious Disease. You cite them in the chapter, and they describe the terms mothers, women, and girls as stigmatizing terms that should be avoided. That's absolutely extraordinary to me that women is a stigmatizing term. It seems that what they are concerned about is that some woman who has transitioned and identifies as a trans man will feel stigmatized by references to women as a sex group. And that's to me, a very convoluted and far-fetched opinion. And it seems to feed into a general confusion about whether changing language can actually change reality. And that's one of the things that is muddying the waters here, and which I would like to just see healthcare professionals steer well away from. I can see some parallels here with kind of fat activism.
Yes.
Where some people were claiming that doctors shouldn't be using terms like obese, morbidly obese, etc., shouldn't be weighing people in surgeries, shouldn't be advising people of the health risks of being overweight, etc. And I think that doctors, it absolutely isn't the role of doctors to be sociologists or queer theorists or psychologists or to be using the most flattering language or to be suggesting what is and isn't socially acceptable. There should be just, to the best of their ability, they should be giving you the concrete information about the fact of the matter, which may be that you are overweight. I used to be overweight and I feel no stigma about it, but I think it's good to know whether you are overweight or not. It's especially good to know if you are obese and at risk of health issues. And I think Zempic has rendered the fat activism movement basically moribund. I think that will kind of play itself out pretty quickly. But for a while, it was a very dangerous movement because the suggestion was if you just didn't describe yourself as fat, then therefore you had none of the physical health dangers of being fat. That all of those dangers came from stigma, i.e. the words that other people said about you. And it feels as though we're entering that same territory here. Do you think that's a fair comparison?
Yeah, so I think there are definitely similarities there. And I think one of the issues, and I didn't really raise this in the chapter, but something that I've seen is that a lot of people working in health organizations, other sorts of organizations as well, the rise of the lived experience person who contributes to development of guidelines or materials. And I mean, lived experience is what we used to call anecdote, so
Yep.
it's the personal experience of one person. And I'm not saying that it's not useful to talk to particular individuals who have a personal experience of a particular issue. But I think that research should be the thing that underpins guidelines in particular, but also health communications, and that you shouldn't be putting lived experience, personal experience on a pedestal. But if you're in a group, if you're a group of doctors or policymakers and you're working on developing a guideline or you're working on developing some sort of health promotion material and you've got somebody in the group who's saying, this is my experience. I am the lived experience expert and I find that offensive and you shouldn't say that. And if you say that, then you're racist, transphobic, whichever slur you want to use. It's really hard to actually say, no, actually you're incorrect. And we're not, that is not an evidence-based approach and we're going to do something different. It's actually really difficult to do that. I have been personally in that position where I was called racist for suggesting that it might be important in developing health materials to speak to or to take consideration for groups that have demonstrated lower literacy or health literacy. And it's not a very pleasant experience. I think that's happening a lot in organisations. And you do need people to be able to just say, no, that's not the case at all. And, I know that's your opinion and that's your experience, but this is not an approach that we should be taking because it's not going to have good outcomes.
Yeah. I think just returning for a moment to the transgender issue, one of the confusions is that there are completely different approaches among the trans people as well, and completely different wishes. There are many biological men who've transitioned and now identify as trans women, want to be referred to with sexed language. They want to be called women and mothers, etc. And while many biological females who've transitioned to being male wanted desexed language, this is just adding further confusion and eroding the ability of medical professionals and scientists to describe clearly the biological facts of how things are.
And you end up in a bizarre situation where people are very happy to talk about women in general when you could consider it a mixed sex group. So you could talk about women and heart attacks. People are fine about talking about that. But as soon as you talk about pregnancy and it's completely sex specific, it becomes birthing people. And,
Yeah.
it's really bizarre. It's very noticeable. It's absolutely very noticeable. So, yeah. Yeah, and what you were saying, generally health communications and research around men and male-specific situations has not been changed. The focus really, really is on female biology.
Yeah. Is there anything I haven't asked you about that you hoped I would ask you about in relation to this, or anything that you wanted to talk about or mention that we haven't covered?
I mean, I think I would just really like for people to consider, looking at this globally, because a lot of my work is in global public health, the impact that this is having on places where, sexism is so bad, and the plight of women who are mothers and of their children is really terrible. How can we accept that it's okay to impose this way of speaking about things that comes from the West? It prioritizes this very Western idea, and the same people who are saying we should change our language are also talking about, colonization was bad, we need to decolonize everything. There's such hypocrisy there, and I don't really understand it, but I would encourage people who are working in this space to really think about the global implications, because it's always the most disadvantaged who are going to be most adversely impacted by these changes that prevent us, firstly, that dehumanize, but also that prevent us from really recognizing, from my work, it's the importance of mothers to their children, their unique importance of mothers to their newborn babies. If we can't clearly identify the mother in language, then we cannot protect and support her in her care for her baby. I mean, it's obviously my area of work. I'm very passionate about it. But I think that other people should be thinking about, what the global implications are as well.
Thank you very much, Karleen. It's been a pleasure to talk to you.
You're very welcome.